is the panel's initial response to the story through the prism of the patient, the nurse, the occupational therapist, and the clinician. I mean, you can take that to mean whatever you want. I take it to mean that you could use your imagination to decide how it might appear to those different groups of people. I'll just throw it out to the panel, first come, first served.
Thank you.
Yeah.
Thanks, Ashok. Applying a patient lens, this is my response to George's experience. The consultant's approach was factually correct, but it was one-dimensional. There appears to be a lack of compassion in the consultant's delivery of facts, and we see little evidence of a holistic, person-centered approach to clinical care. The consultant didn't display an understanding of how George was receiving this information, or invite and provide the space to attentively listen to George and explore his needs, wishes, and preferences with regard to the medical issue, his wider context, and the decisions that needed to be made. Finding out what is actually important to George and engaging in a shared decision-making process. One consequence of this approach was to cause unnecessary anxiety and suffering for George. The Montgomery ruling outlines a model of consent based on the autonomy of patient choice through shared decision-making with their doctor. George's story could be an example of the letter of the law being carried out, but it was not accompanied by an understanding of the spirit of the law. What do I, as a patient, value in a clinical encounter? Academic prowess is not necessarily at the forefront of a patient's expectation. What matters to me is the importance of engaging with a clinician who takes both a values-based and evidence-based approach to person-centered clinical care. I value a compassionate clinician who has the necessary advanced communication skills to attentively listen, nurture trust, and build up my confidence and hope towards achieving my goals. A clinician who sees me as a person before being a patient, and one who uses a relational approach to a therapeutic partnership. Also, a clinician who has the clinical approach and skills to support balanced decision-making in practice, and who recognizes the importance of striking a balance between being risk-aware and risk-adverse. Had these elements been part of George's clinical encounter, his anxiety levels would have been much less, and he will have felt reassured in the decision-making process that was happening. Thank you.
Okay, thank you. Thank you, Perian. First of all, let me apologize. I know you were scheduled to go first, but I've written so many notes, I'm afraid that got a little bit buried, but do apologize. But good points, obviously, which I'm sure we would like to explore in more depth. The next person I have on my list now, I found it, is Laura. Could you give your response, please, Laura?
Yeah, thank you, David. I think it's quite hard for me to separate this from the view of the nurse and the view of a very concerned and loving friend. From the nurse's perspective, I have throughout my career clinically witnessed many conversations that were compassionless and were driven by science and were driven by fact and statistics, and then had to pick up the pieces. And I imagine, and we'll get into this conversation, I hope, as this develops over this lunchtime, is that others will chime with that fact that others often, not always, but often have had to pick up the pieces of and then adding in the caring part. And one of the things that, and I don't want to eulogize here, one of the things that always disturbed me about nursing, which is my first profession, is that we love that fact of saying we're the caring profession, and how dare we, because every practitioner I have ever worked with or had the pleasure of teaching have had a caring lens of what they're doing. However, at times in the heat of battle, in the moment, then that person, that patient, that service user can be left feeling uncared for and undervalued. Through the lens of the nurse, what I am seeing in the cold light of day of this story is not that two-footed approach of values or what was important. So I felt very much that the cardiologist was thinking about what was important to him, which was telling this person about his statistical success, and that this was a very successful procedure, but did carry risks that went with it, but it was successful. But my friend George was able to make a decision for himself because he was a phenomenal researcher. But what I think from looking from the lens of a nurse was the compassion part had such a profound impact on George that if he was anyone else or someone else, he may not have been able to make that decision for himself, because his narrative as a result of the consultation was completely and utterly dominated by the fact that he felt uncared for and he felt alone. And from a nurse's perspective, that is so very much high up on our agenda about this person must not feel alone, they must feel supported and they must feel cared for. So I think ultimately he was let down on multiple perspectives, but not from a scientific perspective, not from a fact perspective, and possibly not from the rules of consent perspective. And I'm hoping that we will exercise this conversation as we go on. As a nurse, it makes me desperately sad for this person that we weren't able to provide a compassion-filled consultation appointment, and that was secondary to the science. Thank you.
Oh, thank you, Laura. That's fascinating and really important to know from the nursing perspective. And I know my partner's a retired nurse, and I mean, she's fantastic what she used to do, but I do know that the reality is quite different from what you ideally would like. As much as you want to do all these things, sometimes it's sort of impossible, and even to this extent that you're criticized for being compassionate, but which she has been many times, so we'll maybe pick that up a bit later on. But could we move over to Stephanie now, if that's okay, for your reaction, please?
Hello, yes, thank you, David. And thank you to Laura and Verian for their lovely reflection of George's story. Many aspects would also reflect my own thoughts of listening to George's story. I think my starting point would be equally as an occupational therapist, and as occupational therapists, we do very much begin from that place of values-based, what's important to the person, but you also very quickly realize that when students go out into certain settings, the dominance and the culture of certain settings begin to override all these aspects of adopting a person-centered relational-based approach. So that becomes very challenging, but it can be done. And I think what I heard in George's story was that this encounter probably ticked all the right boxes. The letter was sent out, the appointment was delivered on time. But the most important aspect of that encounter was completely missing, the relational aspect. And really, George became lost in that encounter, and it very much became about the condition and the mechanistic reductionist approach to what could be achieved with the condition, as opposed to George, the person. And I'm thinking as an occupational therapist where you would meet George, and in an acute setting, that would be very dominated by certain pathways as to how you would get George up and hopefully returned home. But even in encounters in the home setting, they can be driven by process and procedures, again, that lose sight of the person, and people are compartmentalized into their condition. So the first thing for me would be about George, the person, and what mattered to him, what was important to him, appreciating that the safety of his condition and how that affects him would be very much uppermost in the background as well. But I think it is that encounter of asking George, what matters to you, what's important to you. So if I do this and you do that between us, I'm sure we can arrive at something that is going to enable you to live your life in a meaningful and purposeful way. And I think the person always has to feel that that is possible, albeit with limitations and restrictions. But unless that person has a sense of coherence and manageability in their life, then that can have such an adverse effect on the person. So in thinking about the encounter, that for me was the most important part that was missing, but respecting what the consultant had to do. But he could have done that, I think, with some compassion and understanding of George, the person, but still arrived at what he needed to achieve for George in a safe outcome.
Thank you. Thank you very much, Stephanie. Yeah, I'm not sure whether to ask the question. Yes, can I just, because Bill isn't here, so we've got a little bit of leeway. Can I just ask a quick question of Laura? Sorry, Stephanie, but I'm just interested in something I read, my scribbles. Laura,
Yeah.
does it make a difference? What you said, I didn't realize this when I heard the story before. But George agreed to it, and you said he'd made his mind up before the consultation.
Yeah.
I'm just interested, does that make a difference?
Yeah, I think that's a really good question, and this is the part that I spent a lot of time reflecting on. He had made his mind up about this based on the statistics of his pre-reading before going to the cardiology appointment, because he had the ability, and I'm not saying other people don't, but he had the ability to interpret the statistics, the guidelines, the evidence, the publications. So he had done a lot of research to understand where he wanted to be with this. And therefore, if he had been offered, he was expecting to be offered a cardiac ablation. And if he were offered that, he was expecting to say yes. So that was already in his mind, a predestination. If the cardiologist hadn't offered that, he would have asked, is this a possibility? In the consultation, he was offered it. But the part that has stuck with me from my friend telling me this story was that all of his narrative was around how he was made to feel in the appointment, and that was superseding the point where he then said, but I'm going to go for it. And he's told me it's not an inconsiderable procedure, it comes with risks. But when we revisited his conversation and his anxiety in the lead up to the procedure, he reverted back continuously to the feeling of being alone, and it wasn't a shared decision. And it took a long time in our conversation for that to come to light, for him to be able to sort of nail that moment of, but I felt completely alone in this. Now, my concern around that was completely around that if he hadn't done that level of research and didn't have the understanding that he had, his feeling of aloneness was adding to it already was adding to his anxiety. But if he weren't able to have done that, would his anxiety been even greater? So in the lead up to the procedure, he was terrified by it. And I believe completely, as Berrien mentioned right at the beginning, that his anxiety was increased by the lack of humanity, or his perception of lack of humanity in the initial conversation.
Okay, just one last quick one, because just for clarification, was the cardiologist aware that he'd made his mind up already?
No, and that didn't come up in conversation. And he said I'd sort of kept my powder dry because I wanted to hear from the expert.
Yeah.
He understood that he had background knowledge to take to the appointment, but it wasn't a given that the cardiologist didn't know he had made his mind up.
Okay, that helps a lot, actually. So can we turn to Ashok now for your initial response to George's story?
Yeah, I mean, I guess in a way it depends a little bit on how long this cardiology has been a consultant, how they've been trained, because there is this very medical model of care where we think about the healthcare practitioner, in this case the doctor, as expert, and hence people might think that their role is to advise or recommend a particular course of treatment or particular course of action, whether it's a diagnostic and so on. And I hope that we've moved away from that to a model of person-centered care and shared decision-making, where we're involving our patients in the decisions about what course to take, whether it's in the diagnostic process or, as in George's case, in the therapeutic arena. And as I said at the beginning, Montgomery has allowed us to really focus on that and say that at that point of decision making in the patient pathway, we should have shared decision making. And unfortunately, I think some practitioners, and sadly, this has been in part fueled by some of the Royal Colleges, including two of the Royal Colleges that I'm a fellow of, the Royal College of Surgeons of England and of Edinburgh, where they gave guidance. And the guidance came out very much towards their interpretation of Montgomery was that you as the practitioner must discuss all possible treatments and risks, even to the extent of very rare, unlikely events. And so we've ended up with some people looking at that and thinking about two mistakes I think people make. One is they end up practicing rather defensive medicine to say, well, my job is to tell you all the risks, and then at least I've done due diligence. And then if one of those risks does happen, then it's not about apportioning blame. And if that happened, that would be really sad that was the way medicine was going. The other side of it is where some people have misinterpreted Montgomery, that it's become a consumerist model, that actually your job is to outline the options, as this cardiologist did to George, and say you can have option A, B, C, these are the risk benefits, and you choose, and putting the decision back to the patient. And I got the feeling very much with George that that's what had happened. And of course, in my view, that's a complete obfuscation of responsibility on behalf of the clinician, because there's nothing shared about saying, I'm giving you the information, I'm a technical person, expert giving you information, and you decide. But and of course, I have to say that maybe over 8 years ago, there were times when I practiced medicine, sometimes like that, said, look, actually, you have a number of options and you can choose them. Whichever one you choose, I will support you in that. But when you say that to patients, my experience is that over 80% of them turn around and say, well, thank you very much for that. You've now given me the expert information. What would you do, doctor? Or what would you do, nurse? Or what would you do if you're the occupational therapist or physiotherapist? And that's where the expertise comes in. So I just want to finish by saying the definition of evidence-based medicine was best evidence, clinical expertise, and experience. And we've done a lot of that in the last 25 years with this whole push towards evidence-based medicine. And people have forgotten David Sackett's original definition was the third arm of that, was to say, taking into account patients' values, what was important to them. And I think what's missing in George's case is the explicit thing from Montgomery, which says you should enter in a dialogue with the patient to the extent that they understand what the options are and what those mean to that individual in that particular circumstance. So I know that's a rather long commentary, but I hope that's helpful to say where I think from the clinician's point of view, there are pitfalls with Montgomery, and we must educate our workforce to make sure they don't fall into those pitfalls and traps of either obfuscation or defensive medicine or a consumerist model of healthcare.
Thank you, Ashok. That's really helpful. Just one quick question to you. As you were talking, it occurred to me. What's wrong with if the cardiologist or any other clinician in consultation with a patient, what is wrong with them saying, well, you know what, if I were you, I'd do this?
No, that's a really good question. And of course, that's what sometimes for confidence, that's what patients are often seeking, to say, if you were in my shoes, what would you pick? And the problem I have with that, David, is that we make a lot of assumptions. We assume that everybody else thinks like me and are made in my image as practitioners. And what values-based practice teaches us, and we do some exercises, are that there are lots of shared values, but lots of values that are not shared. And also values are very context specific. And so unless you enter that dialogue to find out, you know, what's important to that patient at that time, sometimes you'll be very surprised with what they say. And I'll give, if I've got time, I think, to give one quick example. We run this exercise on a forced choice, and we had two young surgeons working with us, and they were asked to make a choice on a hypothetical decision of how long they'd pick to have a particular treatment over a 50-50 kilocure treatment. And I can talk about their names because they've published this openly, their names, Zoe Barber and Tom Dobbs in the BMJ. And Tom picked 18 months and Zoe picked 30 years and with the same evidence base. And Bill, who sadly can't be here today, said to Tom, why did you pick 18 months? And he said, oh, well, I'm halfway through my doctoral studies. In 18 months, I'll have completed and I want to finish them. And so he then turned to Zoe, because there'd been a bit of argy-bargy between them that the rest of us could hear, and said, well, Zoe, what did you pick? She said, well, I picked 30 years. He said, why is that? He said, well, we just got engaged 3 months ago and I'm planning the wedding and the children and so on. And so she said for her, the light bulb came, because she said, I had assumed I knew what he would pick and what he would choose. And if he'd asked me, I'd have said 30 years for him, but he was thinking something completely differently. And she said, if I could not even understand what a partner of mine for 7 years, who I was planning to spend the rest of my life with, was thinking, how could I know what my patient's thinking unless I ask them? So I hope that's a very long answer to your question, to say there's nothing wrong with giving that, but you have to know whether the person you're giving that advice or making a choice for actually has the same things important to them as you do.
Yeah, I think that's an excellent answer, if you don't mind me saying. I mean, in other words, everybody's unique, and we don't know what matters most to them. Simple as that, really.